Hello and welcome to the Clinical Care Options Infectious Diseases podcast. I'm your host, Anna Popper. Today's episode is part of an ongoing series on addressing key challenges in the management of viral hepatitis. This series features conversations between a patient and a clinician where they discuss developments designed to improve access to treatment and care of patients with hepatitis. In this episode, Dr. Robert Gish of Loma University talks with Jacki Chen, a patient advocate from New Jersey. Jacki was diagnosed with hepatitis B 30 years ago and supports the Chinese-speaking community through the Taiwan Hepatitis Information and Care Association, THICA. For more information about our guests and for a link to additional online education on this topic, please visit the link in the show notes. So, Robert and Jacki, thanks very much for joining me today. We're delighted to have you on the program.
Okay, Jacki, greetings. This is Dr. Robert Gish. I'm just here to understand the patient journey from your individual perspective and also your knowledge, your interactions, your understanding, what you've heard from other patients. And let's start with a background about when you were diagnosed with hepatitis B. What were the circumstances? How did you feel? What was your emotional response, your intellectual response?
Hi, Dr. Gish. Very nice to see you again, and thank you very much, and thanks everyone for listening in. This is Jacki. I'm from Princeton, New Jersey. I was diagnosed with hepatitis B about 30 years ago. The positive test for Hep B was not a surprise to me because I was just informed by my family member to get tested, because they were all tested positive for hepatitis B back in Taiwan. And also because the situation that my brother was diagnosed with liver cancer and liver cirrhosis already, and that was caused by hepatitis B. So the burning question for me at that time is that would I be develop liver cirrhosis and liver cancer very soon? So that anxiety has been with me ever since until now. I still have that anxiety. So after that, I was referred to a specialist and did more blood tests and liver biopsy, and I found to have a very severe fibrosis, I think around F3, and have active hepatitis, the ALT about 100. My doctor referred me to a therapeutic vaccine trial, a clinical trial, using the peptide vaccine at Scripps Research Institute at that time. So more testing was done, but unfortunately, I dropped out of that clinical trial because of family issue. So later on, I relocated to another state, to Massachusetts. And in fact, I didn't follow up while I was in Massachusetts for almost 6-7 years, probably because that I knew at that time there were no good treatment at that time, except interferon, and then later on a first-generation antiviral that was developed, but it has high rate of resistance, so I didn't really bother to get treatment. But after that, I moved again. 7 years later, I moved again to New Jersey, where I am now, and I started to feel some symptoms that I don't feel comfortable on my liver area. So I decided that I should start to look for a specialist, a doctor, to help me to monitor my liver condition. So I was found to have continuous elevated, although it's mildly elevated, liver enzyme around 150 to 100, about 1 to 2 times upper limit. And my viral load was not very high. It was like 2,000 to 10,000 within that range. But I started to experience some symptoms. That worries me a lot. So I went to a specialist and I started the treatment at that time. That treatment was actually because of my family member back in Taiwan. They all started to take entecavir when it first came out because of the low toxicity and low rate of drug resistance. So I've been entecavir and then follow up with tenofovir and with TF now, and everything has been okay for me, and I remain in F2 and F3 fibrosis stage, and everything still goes fine. I haven't had any liver cancer yet.
Let's go down this separate but parallel road about what you were feeling about the diagnosis and maybe address questions about fear of cancer, transplant, liver failure, and stigma.
Yes, of course, because I was tested positive, and that was because my brother already have liver cirrhosis and already have liver cancer. So he got treated with liver cancer, and then he started antiviral, the first generation antiviral, second generation, and then later on. So he has been on antiviral for many decades now. Anxiety has been with me ever since. So at the same time, I feel isolated as well. Most of the time, I do my own work and didn't really socialize that much. So that is kind of stigma. And at one time, I actually told my coworkers that I have hepatitis B, and they didn't want to like eat with me, something like that. So, but that was back in 20, 30 years ago.
What about today? Do you feel that stigma is an issue you deal with, or the patients and the different support groups, your networks?
Yes, so today I think it's much better in a way that I'm under treatment, and I know that my viral load has been undetectable for decades. And although I still have some fibrosis, everything else looks fine. And we also started to form a social media support group, and that helped a lot because once you open up yourself, describe your situation, and then you help other people to understand the issue, that supporting help a lot to alleviate any isolation or any feeling
Great.
of stigma.
What about resources that you used or you would point people to today? Where can a patient go to get accurate, reliable, and deep information about hepatitis B?
Yes. So obviously, the best information they can get would be from their physician because their treating physician knows their situation the best. But besides that, I think the support group is very helpful in a way. The support group is almost running like 24/7 in a way that there's always somebody to help to support. At the same time, there are a lot of online resources that are available that you can look online. Right now, if you Google it, there are a lot of Hep B Foundation or many other resources, CDC, many other resources that has a very accurate and positive information there that you can find.
I remember seeing you last in Taipei, and
Yeah.
you, as a patient being there, I was very pleasantly surprised. Do you recommend patients to go to specialty meetings?
Yes. Obviously, for those patients who are interested and involved in, for example, advocacy work, then they need to sharpen their knowledge. They need to get up-to-date information. And those meetings are those places that you can get up-to-date information by talking to specialists, by be able to interact with them and know the latest information.
I brought that up because AASLD has really accelerated their patient involvement. And at the last meeting, our annual meeting that was held in November online, there were patients on many of the discussions and chat rooms asking questions of panels. I was very pleasantly surprised by their presence and by the sophistication of their questions. So I really want to make that point and emphasize what you're saying. Search out a specialist, search out the specialty societies. There's meetings, there's websites, there's a lot of resources to make sure we don't have misinformation out there about hepatitis B, including vaccine safety. I do have a question about when you were moving to Massachusetts, then New Jersey, did you have trouble getting in to see a specialist?
Yes, because at that time my insurance was, I think, with HMO, and I have to see a primary physician and rely on the primary physician to refer me to a specialist. And if the primary physician feel like he's doing a good job, he did all the regular monitoring, and my liver enzyme although is elevated, but it's not too high. So he seen that I have no danger, and he just keep monitoring. And actually, I have done that from 2003 until 2008, almost 5 years without doing anything and just routine monitoring. And I keep telling the physician, the primary care physician, I feel discomfort, I worry about liver cancer, and is there's any way to get treated? And I was referred a couple times, but still I wasn't really started treatment. So this is my question for you, Dr. Gish. If you don't mind. So for my situation, in fact, I decided to look for infectious disease specialist, and he started me on treatment. And that is actually a sort of a consensus, is that I also wanted to get treatment. because my brother already have liver cancer, liver cirrhosis, and I worry about that constantly. So he put me on entecavir. So, but you know that according to, I think, AASLD guideline or Apostle guideline or whatever guideline, that for my situation like that, I was not qualified for treatment. And actually, because of my insurance, they pay for that, so I'm okay. But for patients in Taiwan, for example, they were left out. They cannot get treated if in a mild condition like that. But who knows? If I didn't get treated that early, I could be in cirrhosis right now already, 10 years later, right? What do you think?
Jacki, you are highlighting what I think is one of the biggest barriers to treatments, which is these complex guidelines that are 20, 30, 40 pages long. Nobody reads them. Nobody understands them in the primary care community. And they're a barrier. That's why we're only treating 1 out of 5 people who are candidates for treatment today. So this is the biggest barrier. And there's a big move from the advocacy side to make the guidelines much simpler and treat hepatitis B as a pre-cancer state and as an infectious disease. And if you do that, we're going to treat everybody who's DNA positive and forget about 20 pages of documents in the guidelines. What do you think about making it really simple?
Yes, I like the simple guideline in a way that the patient can get treated as, if they want. Obviously, the patient still have a choice, right? If they think that, well, they don't want to be on medication, I think that's their choice. But I think it should be made available to them and should be simple to them. And also to the treating physician. I think you suggested that anyone with viral load above 2,000 be treated, and that would be a simple suggestion. But for that, I do have a question. One argument is that, for me, I have several family members in their 20, 30, and they are not on treatment. They have virus with them for life, and they have very, very high viral load. And obviously, one question is that if they started on treatment now, do you think for long term there will be no toxicity, or there will be no drug resistance, or will it eventually help them? What do you think about those situations?
2 great questions. So from an expert perspective, the safety of entecavir, TDF, and TAF is exceptional. There are very rare side effects of entecavir that have been published in really only 1 manuscript, I think. TDF long-term had some bone health and renal health effects, and that's why TAF was approved, which has very minimal kidney or bone risk. So I think these are extremely safe, and it's a risk-benefit balance. The benefit of taking these medicines is 100 times more than any risk. And when you have 100 times differential, no transplant, unlikely to get cirrhosis, very low likelihood of cancer, the benefit outweighs risk. Take these long term, but we're not using the word forever anymore. We're hardly even saying indefinite. We're telling patients that there are 30 new hepatitis B medicines in development. And within 3 to 5 years, the treatment paradigm will change, and we'll have a lot more people getting to functional cure, which is S antigen loss, which is really the ultimate short-term goal. But as we suppress virus to undetectable, and this new trend, Jacki, is to treat any patient who's got DNA in their blood. Forget the 2,000, forget the 20,000. DNA positive, higher risk of cancer, higher risk of transmitting infection, put them on treatment. That's the simplest guidelines I could think of and what we are really advocating for from the advocacy side. But I have a question for you about this. If a patient's got a high viral load versus a low viral load, is their feeling of health better? Is their stigma, self-stigma, societal stigma less if they have much less virus in their blood?
Absolutely. That's one of the most important things we want to be on, or I wanted to be on treatment, because I don't want to carry a virus in my blood and, you could risk transmitting it to anyone near you. So I think that is one of the major things that can benefit the patient and benefit the society as well. But for stigma, there's one thing is that if for the patient or for a young person, if they want to be on treatment, it seems like that they're going to have to be exposed, or they're going to have to be, telling their friend that they are on medication. I don't know whether that is good to them or they are concerned about that or not, because that happened to one of my relatives who is in California right now. And I have hard time to persuade her to see a specialist and to get treated though.
Yeah, you're right. There's a stigma of having the infection and there's a stigma of taking a medicine. But most of the patients I've talked to feel like the stigma of infection is much greater than the stigma of taking a pill every day. When people have hepatitis B and they take one of these oral medicines, their risk for liver cancer has been proven to fall by about 70%. So we have great long-term data that these medicines prevent cancer. It's not 100% prevention, but if someone says you're in an airplane that's crashing and there's a 70% chance that you're going to be alive, you're going to be very happy about that. So I really think that there is great data about decreasing cancer risk. I'm very happy about that. I think in summary that hepatitis B is an infectious disease. That's a reason to treat everybody. It is the most common cause of liver cancer in the world. And we have very good proof that by treating, including immune tolerant patients, we're going to decrease liver cancer. So we have the stigma, we have infection, we have liver cancer, we have cirrhosis, we have transplant, we have death. Let's make it simple. Test everybody, vaccine to everybody who's triple test negative. That's all 3 tests are negative. Don't boost. And then everybody who is HBsAg positive gets a DNA test. They're DNA positive. Let's get them on a nuke. And as new medicines come out, we'll get to a higher rate of functional cure. What do you think about that as a wrap up? And Jacki, what would you like to say?
Yeah, super. That is great. I think that would make the primary care physician's life much easier. It's very easy, simple to follow, and make the patient happy as long as the medication is covered by whatever insurance. That would be great.
Thank you.
Thank you, Jacki and Robert, for sharing that conversation with us. I really appreciate your time today.